Hi everybody, welcome to the January 17th half-day talks. Today we'll be going through glenohumeral arthritis, and in this podcast specifically we'll focus on non-op treatment in younger patients. Just a quick thanks to Dr. Lowe and Dr. Bois. Today for our objectives, we'll explore different non-operative treatment modalities, including physiotherapy, various injections, and pharmacotherapy. So just a quick review of the etiology. Usually patients under 50 are with advanced arthritis are most likely to have a secondary cause for severe disease, and patients less than 50 are usually going to have post-traumatic causes such as dislocation, fractures, or osteonecrosis or post-operative changes. So we'll jump right in and we'll start with medication. So medication is really a temporizing measure for pain relief. So different kinds you can use: NSAIDs, Tylenol, and codeine have shown effectiveness in arthritis pain. However, they obviously don't change the natural course of the disease, and we do want to try and avoid narcotics if at all possible. And as always with medications, you need to educate your patients on the risks of using medication, especially long term. So next, moving on to physiotherapy. So there's a lacking of good evidence showing benefit for osteoarthritis in shoulders. However, it likely is beneficial for preserving range of motion and as an adjunct treatment to prolonged time to surgical management. And there is an official AAOS guideline on glenohumeral arthritis from 2010, and they looked at it again in 2014. And specifically for physiotherapy, they are unable to recommend for or against its use in glenohumeral arthritis. Their main point for that is that there is a lacking of good quality evidence showing that it is effective or not effective. Despite the lacking of good evidence showing long-term benefit, though, physio poses very minimal risk to patients and is helpful for preserving range of motion. Especially for younger patients, like we're trying to focus on in this talk, to get as much range of motion as possible is key. So next we'll move on to injections. So we'll start with corticosteroid injections. So specifically for shoulders, there are no level 1 or level 2 studies showing effectiveness. Its use and its effectiveness is largely anecdotal, and evidence is derived from studies showing benefit in other arthritic joints, mainly knees. So they do mention corticosteroids in the AAOS guideline, and they are unable to recommend for or against, citing lack of evidence. I did come across a guideline from a sports medicine journal that outlined how you would treat early glenohumeral arthritis in young athletes. And they did recommend a trial of corticosteroid injections initially, and if this was effective, and that you could repeat this every 6 months. You don't want to do more than 2 per year. They did also say, though, that if your initial injection is not effective, so if there's less than 3 or 4 weeks of symptom relief or minimal symptom relief, that they usually do not do any further injections, as they're unlikely to provide benefit. And next we'll move on to hyaluronic acid. So hyaluronic acid is naturally present in your synovial fluid, and it's been shown to be decreased in osteoarthritis. It kind of acts as a bit of a shock absorber. It increases viscosity and elasticity of the synovial fluid. So this is the only injection and treatment modality that is endorsed by the AAOS guideline. So they say use of injectable viscosupplementation is an option when treating patients with glenohumeral arthritis. At the time, they based their recommendation on a study done by Silverstein et al., which showed that there was improvements in functional outcome and pain scores for those who had hyaluronic acid injections for arthritic shoulders. So more recently on the topic, there was this systematic review that I came across published just in 2018 from Hamilton. Looked at 15 studies, 5 were randomized control trials. They looked at almost 1,600 patients. So they were looking at, is hyaluronic safe and does it reduce pain in glenohumeral arthritis? So they found overall the aggregate results of the study show that there was a decrease in pain visual analog scales at 3 and 6 months post-injections. They also did show that there was functional outcome measure improvements as well. They did state, though, that in their control groups that there was a significant placebo effect um, to basically sham injections of the shoulder. So to keep that in mind. Some of the other limitations of the study, there was no standard injection process. So 7 of the studies that they looked at did blind injection techniques, so no fluoro or ultrasound guided injections. And for us, for this podcast specifically, they didn't focus on young patients. And I looked into platelet-rich plasma. So there's no level 1 studies done specifically for glenohumeral arthritis. But much like corticosteroids, I think the evidence and the efficacy is going to come from different populations. So most likely the knee osteoarthritis patients. There are RCTs in those with knee OA looking at platelet-rich plasma. So let's go over one of those real quickly. So this was a systematic review from 2016 that looked at PRP in arthritic knees. So they looked at 7 studies, only one was double-blinded. They had 740 patients basically, and they either compared PRP to hyaluronic acid or PRP to placebo. And they showed overall that WOMAC scores were increasing in the PRP groups at 3, 6, and 12 months post-op when compared to hyaluronic acid. So I'm not sure how much you can totally transfer that over to the shoulder world, but there's some evidence in osteoarthritic joints for PRP coming out. So just in summary, early glenohumeral arthritis is difficult to treat in young patients. You don't want to jump just straight into surgical options. Different modalities we talked about, medications. It's not going to treat the pathology, but it can help with symptom relief. And physiotherapy, it's not recommended for or against by the AAOS, but it likely is beneficial for symptom relief as well as preserving function. And then we looked into some injections, so potentially effective, and although most of the evidence comes from the knee osteoarthritis studies. However, hyaluronic acid is currently endorsed by the AAOS for glenohumeral arthritis. And then just quickly, last point, PRP is showing some promise in knee OA. However, we don't have any level 1 or 2 studies showing its use in shoulder arthritis. All right, that's it. There's my references. Thanks for listening.